Thank you, Diraj. My name's Syed, and I'm a electrophysiologist, the cardiac heart rhythm specialist from Bart's Heart Centre in London. And I'd like to thank the organisers and AtriCure and the panel today for inviting me to speak. So I've been asked to talk a bit about the impact of long-standing persistent AF, and I apologise in advance because I'm then going on to talk about some of the hybrid techniques that we're currently adopting to treat AF. So really, with AF, the first question is, why is it important? Why are we treating it? It carries a 5 times risk of stroke compared to someone who's in sinus rhythm, a significantly increased risk of heart failure, and a greater risk of all-cause mortality. More recently, there's been data to support the fact that it increases the risk of dementia significantly. 1 in 3 of us will develop AF, and it's becoming increasingly common. And it's a disease that occurs as we get older. Now, in America, there's an increasing prevalence of AF, and this is expected to continue to rise. By 2050, it's going to be significantly higher than we are now. So it's a problem that's not going away. With an increasingly aging population, it's going to get more and more common. But not only that, if we look at the cumulative incidence of events in 5 years after a diagnosis of AF, and this was in inpatients, Medicare inpatients in America, after 1 year, the incidence of mortality was 20%, and the 5-year increase in mortality with a diagnosis of AF was 49%, so really striking data. But not only that, there's an increased incidence, once you have a diagnosis of AF, of heart failure, stroke, and MI. As I say, there's more data emerging regarding the correlation between AF and dementia, and if you look at the graph at the bottom, you'll see that this is across all types of dementia. So in green is a diagnosis of AF, and in yellow, the bar chart shows patients who don't have AF. So regardless of the type of dementia, we know that AF increases its incidence. And the mechanism of this is likely to be multifactorial. So as you can see from the diagram, a combination of things, microemboli, hypoperfusion, amongst other mechanisms. And more research is going in to try and clarify the relationship here. So if we move on to the cost of AF, how much does this cost the NHS? It's actually really significant. In 2000, so nearly 25 years ago, AF cost was 459 million, accounting to approximately 1% of the NHS expenditure. However, since then, as you've seen from the graph, the incidence of AF has increased by about 20%. So significantly increasing in the last 10 years and likely to continue. This leads to an increased cost through hospitalizations, drug treatment, ablations, and GP and hospital visits. So the cumulative cost of AF is not just only on an individual level, but also to the NHS as a whole. This is some Australian data which shows that over the last few years there's been a progressive decline in the incidence of myocardial infarction and heart failure. Whereas in blue you'll see the progressive increase in the incidence of AF. So again, reiterating the importance of why this condition needs to be treated and addressed. So let's just go through AF in a bit more detail. Atrial fibrillation is a progressive disease. Early stage AFib, or what we refer to as paroxysmal AF or PAF, is the initial beginning of the procedure. And we know the mechanism of paroxysmal AF is triggers from the pulmonary veins, the veins which feed oxygen back to the heart, oxygenated blood back to the heart from the lungs. And these veins act as triggers which trigger off AF, and that overrides the normal regular sinus rhythm. Over time, if untreated, this evolves to become persistent AF, where the patients are in AF all the time. And now, not only are the pulmonary veins involved, but we also have involvement of the left atrium, the substrate. As this continues, past 1 year, we categorize this as long-standing persistent AF. And you'll see from the graph, from the slide, that the majority of patients with AF fall into the latter two categories. Now, paroxysmal AF we can treat easily and successfully in the catheter lab with catheter ablations, but the vast majority of patients with AF fall into the latter two categories, which are more resistant to treatment. As AF progresses, it starts affecting the atrial chambers, causing what we call an atrial myopathy. So AF causes enlargement of the atrial chamber, and this leads to a decrease in atrial contractility, and over time, potentially leads to impairment of the heart function and left ventricular function, which Steve will come on to later. In the early 2000s, the philosophy was, well, someone with AF, controlling their rhythm, putting them back to sinus rhythm doesn't offer you that much benefit. If we just control their heart rate, they can stay in AF. And there were two landmark studies, the AFFIRM trial and the RACE2 trial, which were published. And these studies showed equivalence in management with a rate control or rhythm control strategy. However, what we didn't include was, well, these patients are on medications, and the medications have side effects and actually can cause more problems. So it was slightly biased. On top of that, the technologies to treat AF back in 2000 were very limited. So things have evolved slightly since then. Now, there's lots of data showing that catheter ablation for AF and trying to get patients into sinus rhythm is important. And people will say, well, hang on, we can manage this with medications and antiarrhythmic drugs. But actually, if you look at every single drug that we use for AF, there's a significant increase in complications and an increase in mortality. And so it's not a fair comparison because we're not comparing like with like. So whenever anyone is in doubt about the benefits of achieving sinus rhythm and saying, well, drugs are risk-free, as I say, nearly increased mortality with all antiarrhythmic drugs. So our strategy has moved on somewhat now, and our goal is to try and achieve sinus rhythm in the majority of patients. And again, these trials demonstrated significant benefit. The EAST-AF-NET trial of an early patients in early AF, so paroxysmal or early persistent AF, they did better than usual care with medications. The ATEST trial, catheter ablation is better than medical therapy. And the landmark study, CASTLE-AF trial, which showed that patients with AF and heart failure do far better being in sinus rhythm with a catheter ablation compared to medications. So overall, our treatment of AF, our goals and strategies, primarily is to reduce the risk of stroke, improve patient symptoms with drugs that reduce the risk of stroke, such as warfarin and now more commonly DOACs, and do procedures to reduce this risk as well, which we'll come on to later. But also symptom relief, so improving patients' symptoms with commonly used drugs, which are safe, and potentially other drugs or interventions to achieve sinus rhythm.